Regarding the meniscus, fibrocartilage structure, wedge-shaped cross-section area, uh, generate hoop stresses. Medial meniscus cover half of the tibial surface, lateral meniscus almost circular. Biphasic property of the meniscus: on loading, water is driven out, release of pressure. Glucosaminoglykine molecules in the meniscus attract water due to its negative charges. The blood supply is anterior peripheral 1/3 in adult. In pediatric populations, peripheral 2/3. Meniscofemoral attachment connect posterior horn of the lateral meniscus to medial femoral condyle. Ligament of Humphrey is anterior to PCL. Ligament of Vrisberg is posterior to PCL. Provide secondary stabilizer for posterior translation. The lateral meniscus is more mobile. Medial meniscus is more adherent because of the deep MCL attachment. Intermeniscal ligament connect anterior horn of the medial and lateral meniscus. Coronary ligaments attach the periphery of the tibia, more on medial meniscus. Lateral meniscus more mobile. Regarding the macroscopic structure, it has three layers: surface layer, superficial layer, and deep layer. Uh, uh, Superficial are radial fibers, um, support the circumferential fibers. The deep fibers are running circumferentially parallel to the C, and these fibers are connected by the radial fibers, resist the hoop stresses. Because of this shape, the vertical meniscus suture are stronger than horizontal mattress sutures. So vertical mattress sutures are stronger than horizontal mattress sutures. Regarding microscopic, extracellular, um, one type 1 collagen 20%, layers of different oriented fibers to resist forces, circumferential fibers to compressive stress load, dissipating hoop stresses, and the radial fibers connect the circumferential fibers to resist shear forces. Elastin 10%, prostaglandin and water is 65%. Regarding cellular morphology, chondrocytes and fibroblasts, blood supply is perimeniscal capillary plexus. 75% of the nutrition is provided by synovial fluid, while 25% is by medial and lateral geniculate artery, medial and lateral inferior geniculate artery, by perimeniscal plexus. Posterior horn are supplied by middle geniculate artery as well. Regarding medial meniscus, semicircular, attached to deep MCL and to coronary ligaments. Vulnerable to tear, 3 times more torn than lateral meniscus. Limited mobility, cover half of the tibial surface. On MRI, posterior horn is larger than anterior. Medial tibial condyle is triangular, absorb 50% of the load. Lateral meniscus is nearly circular, smaller, cover 2/3 of articular surface, absorbs 70% of the load, more mobile, convex lateral tibial plateau, more movement. Lateral meniscus posterior excursion is twice that of medial meniscus. On MRI, posterior horn is same size as anterior. Lateral tibial condyle is quadrangular. Function of meniscus: number 1, secondary stabilizer, especially posterior horn of medial meniscus is AP stabilizer if ACL is lost. Meniscofemoral attachment, distribute weight, shock absorber, joint lubrication, and proprioception. Regarding the type of meniscal tear, it can be longitudinal, horizontal, oblique, uh, or parabeak, radial. These are the most common types of tear. Longitudinal tear is basically a vertical tear called bucket handle tear when displaced into the notch. Oblique tear is a parabeak tail, basically a radial tear that extends longitudinally. A radial tear as radial. Horizontal is most commonly in old people, makes two flaps, superior and inferior flaps. Um, Otherwise, there are complex tears, beyond the margin of tibial plateau, root tears, commonly in ACL tears, and SONC, repair to bone with the transtibial sutures. The meniscal root tears plays an important role in biomechanics. A root tear is almost equivalent to a total meniscectomy. This is because root is disrupted, means circumferential fibers are not functioning. A locked knee is inability to fully extend, caused by displaced bucket handle tear, cause locking in the same position. Urgent treatment to prevent fixed flexion deformity. This is true locking. MRI finding is in bucket handle tear is double PCL sign, double anterior horn sign, absence of bow tie sign, uh, seen when less than two digital slices demonstrate normal body of the meniscus. Uh, Loss of normal appearance of the meniscus. Normal meniscus are seen as bow tie sign. Ghost meniscus is a sign of a radial tear. Uh, Lateral meniscus is more common in acute ACL injury. Medial meniscus is more common in chronic ACL injuries due to instability causing pressure over the fixed medial meniscus. Management depends on the area, location of the tear, type of tear, and the structural situation. Meniscal debridement to the stable rim. In horizontal tear, resect inferior leaf and trim superior leaf. Um, the function of the knee is inversely related to the amount of tissue resected, uh, also indicated by the tear with history of two previous failed attempts. Regarding total meniscus, normally we do meniscal debridement plus minus partial meniscectomy. Total meniscectomy decrease contact area by 75%, increase forces in medial meniscus 100%, lateral meniscus 100 to 300%, 200 to 300%. And Fairback changes explained in 1948. Fairback changes are squaring of the femoral condyles, peak eminences, ridging, and joint space narrowing. Meniscal repair criteria is red zone or red white zone, less than 50 years old, uh, reducible, single plane tear, root tear, ACL intact, and compliant with their rehab. Some would also talk about the weight and the body mass index as well. It's only indicated in the young population, less than 50 years. Technique of meniscal repair, all inside repair by absorbable anchors. Uh, Inside out technique is a gold standard. It's tied down to the capsule through small incision on the posterior medial or posterolateral approach. Technically, it's difficult. Risk of saphenous nerve vein and dissection should remain posterior to MCL. Risk of peroneal nerve injury on lateral side is also possibility. It's all mostly done for the posterior root avulsions or a posterior located meniscal tear, outside tear, in technique, anterior horn tears, open, refreshen up, and have vertical mattress sutures, give better strength and capture circumferential fibers. ACL meniscal tear have shown that if ACL is reconstructed at the time of meniscal repair, it is 93% healing of meniscal tear repair with ACL reconstruction. The reason is bone drilling releases stem cells and ACL reconstruction protects meniscal repair. Mobilize in brace limited to 60 degree of flexion. Regarding meniscal replacement, synthetic collagen scaffold derived from animals require anterior and posterior horns. They should be intact and only for the part of the rim is transplanted with the collagen matrix. Allograft is possible for young individuals, especially lateral meniscus. Contraindication is inflammatory arthropathy, outer bridge grade 4, previous joint infections, skeletal immaturity, mark obesity. No difference in outcome between replacement and partial meniscectomy. Past guidelines: take a history of a patient with a meniscal injury, examine the patient, identify the sign, especially sharp pain, imaging, X-ray or MRI. If there is a meniscal tear and it's locked knee, you need urgent arthroscopic meniscal surgery. If advanced structural osteoarthritis, there is no need for no arthroscopic meniscal surgery is required. If acute injury with meniscal target, consider arthroscopic meniscal repair. If meniscal target and corresponding sign and symptoms, consider non-urgent arthroscopic partial meniscectomy. Possible meniscal tear and corresponding symptoms and sign. If there is a possibility, give a non-operative management treatment and reassess and decide.